Hey everyone, Eoin Tabb here, and welcome back to the Irish Haematology Oncology Podcast. Grab your coffee and settle in because today we're having a chat about something that can be a bit tricky in our line of work: renal impairment in cancer patients. If you're just starting out in haematology and oncology, or if you're a seasoned pro who just needs a quick refresher, this one's for you. We're going to break down what happens when those kidneys aren't working at their best and how that can throw a wrench into our chemo plans. Okay, so let's get a little nerdy about those bean-shaped organs we call kidneys. These powerhouses pack a punch way beyond just making urine. They're the ultimate multitaskers, playing a crucial role in one, waste removal. So picture your kidneys as microscopic Brita filters, constantly sifting through your blood to remove metabolic byproducts. Stuff like urea, creatinine, and excess electrolytes, things your body definitely doesn't need to hang on to. 2, they act as a fluid balance. Kidneys are the masters of fluid regulation. They sense dips and rises in your body's hydration, either conserving water or prompting you to take a bathroom break. Think of them as your personal water management system. 3, blood pressure control. Kidneys aren't just passive filters. They produce hormones and work with complex systems to maintain a healthy blood pressure. It's like having a built-in pressure gauge and a team of technicians keeping it all in check. 4, red blood cell production. So have you ever wondered where those oxygen-carrying red blood cells come from? The kidney plays a key role in signaling your bone marrow when it's time to crank out more red blood cells. No kidneys, no signal, and that can lead to problems like anemia. And 5, keeping bones strong. Kidneys are crucial for activating vitamin D. Why is that important? Well, active vitamin D helps your body absorb calcium, keeping your bones healthy and strong. They're basically your skeletal support crew. So let's look at the magic inside, those nephrons. So how do they do all this magic? It comes down to tiny, super efficient units called nephrons. Each kidney has about 1 million of them. A nephron is like a miniature water treatment plant with several parts. So one of those parts is the glomerulus. This is a bundle of tiny capillaries where filtration begins. Imagine it like a super fine strainer, letting fluids and small waste products pass through while keeping larger blood cells and proteins inside the system. And then you have the tubule. This is a long, winding tube, and this is where the good stuff gets reabsorbed and the not so good stuff gets concentrated. This is where your kidneys fine-tune what stays in the bloodstream and what gets turned into urine. So let's try and understand renal impairment. It's a broad term, and it basically means that the kidneys aren't doing their jobs at 100%. This can happen for a lot of reasons. So you can have chronic conditions. Diabetes and high blood pressure can damage the delicate kidney structures over time. It's like wear and tear on a finely tuned machine. Acute kidney injury. This sudden decline in function can be caused by things like infection, medications, or even dehydration. It's like your kidneys getting temporarily knocked offline. And cancer itself. Sadly, some types of cancer can directly damage the kidneys. Chemotherapy toxicity as well. Chemotherapy drugs, while essential for fighting cancer, can sometimes harm the kidneys. It's like friendly fire in battle. Okay, let's go into segment 2 and looking at eGFR. So how do we know if those kidney filters are working in tip-top shape or if they're getting clogged up? That's where the eGFR comes in. This number, called the estimated glomerular filtration rate, is our kidney speed limit. So what does it measure? The eGFR tells us how many milliliters of blood your kidneys can filter per minute. Kind of like measuring how quickly that coffee filter can turn water into a delicious morning drink. And calculation matters. It's called estimated for a reason. We usually calculate eGFR using a blood test result for creatinine, a waste product in your blood, and a formula that factors in things like your age, gender, and race. It's not a perfect reflection of actual filtration, but it's the best tool we have for a quick assessment. So let's try and understand that scale. Here's how those eGFR numbers usually break down. So an eGFR above 90, the kidneys are humming along, full steam ahead. An eGFR between 60 and 89, This is a mildly reduced kidney function, so start to keep an eye on things. An eGFR between 30 and 59, this is denoted as moderate kidney impairment. So it's definitely time to adjust some medication strategies at this point. An eGFR between 15 and 29, that's severe kidney impairment. So significant dosage reductions or drug changes might be needed. And an eGFR below 15, the kidneys are really struggling here. This often signals the need for dialysis or considerations for a kidney transplant. So why eGFR matters for chemo? It's the clearance question. So let's connect those speed limits to chemo drugs. Here's where that medication clearance concept becomes vital. So high-speed kidneys equals high-speed clearance. Some drugs zip through kidneys with no problems. Think of a sports car cruising on a wide-open motorway. Healthy kidneys usually mean these drugs get eliminated efficiently, reducing the risk of them lingering too long and causing issues. Slow kidneys equals slow clearance. So if the eGFR drops, it's like our motorway turns into a congested city street. Drugs dependent on kidneys stick around way longer than intended. This is where those dosage adjustments become critical. Otherwise, side effects can get nasty. Imagine trying to maneuver that sports car in gridlock traffic. And it's not just about excretion. Sometimes kidneys have an active role in making medications work. Some chemo drugs are inactive when they enter the body. They rely on the kidneys to convert them into cancer-fighting powerhouses. Sluggish kidneys can mean less of that active form gets created, rendering the treatment less effective. So let's look at types of kidney damage as well. So we've covered how awesome the kidneys are and how we measure their function, but what happens when things go wrong? Kidney damage isn't a one-size-fits-all situation. It's like that car breaking down. There are different parts that can malfunction. So there's pre-renal damage, right? So we're going to continue with our road analogies here. So imagine a truck on that motorway leading to a major city. If there's a massive traffic jam on that motorway, the city doesn't get the supplies it needs. That's pre-renal damage. It means something is obstructing blood flow to the kidneys. This could be caused by dehydration, so there's not enough fluids in the body, means less blood volume reaching those kidneys. Heart failure, a weak heart can't pump blood effectively to the kidneys, and medications. Certain drugs can restrict blood vessels, reducing blood flow to the kidneys. The good news here is that pre-renal damage is often reversible if we catch it early and treat the underlying cause. It's like clearing that traffic jam. Once the road is clear, the supplies can flow again. Then there's intrinsic damage, right? Intrinsic damage is like the depot where that truck was delivering to has broken down. It means there's damage to the kidney's internal structures, those nephrons we talked about earlier. This can be caused by medications. So some chemotherapy drugs like cisplatin can be directly toxic to the kidneys. Infections, severe infections can inflame and damage kidneys. And autoimmune diseases. The body's own immune system can mistakenly attack the kidneys. So intrinsic damage is trickier. Some forms are reversible, but others can lead to permanent scarring and loss of kidney function. It's like that depot needing major repairs. Sometimes it can be fixed, but sometimes the damage is too extensive. And then we have post-renal damage. So imagine now that there's a bridge lift on the only bridge out of town. The trucks can't get out and it starts to back up. That's post-renal damage. It means there's an obstruction preventing urine from leaving the kidneys. This could be caused by kidney stones, so those hard deposits can block the ureters, the tubes that carry urine from the kidneys to the bladder. Tumors, a tumour in the urinary tract can obstruct the flow of urine. And an enlarged prostate. In men, an enlarged prostate can squeeze the urethra, making it difficult for urine to pass. Like pre-renal damage, post-renal damage is often reversible if we remove the obstruction. It's like lowering that bridge. Once the blockage is gone, the flow returns to normal. So why does this matter for us, right? Understanding these different types of kidney damage is crucial. It helps us pinpoint the cause of renal impairment and tailor our treatment strategies accordingly. For example, if a patient has pre-renal damage due to dehydration, we can focus on rehydration and potentially avoid unnecessary dose reductions. Remember, we're not just looking at numbers, we're looking at the whole patient, their medical history and the current condition to make the best decisions for their care. So we talked about that eGFR. So now let's talk about the gold standard for eGFR and estimating that kidney function, the CKD EPI equation. This is the formula we use to calculate that all-important eGFR number. It takes into account your patient's age, sex, and serum creatinine levels. So why CKD EPI? Well, it's been shown to be more accurate and precise than other or more traditional methods, especially in patients with normal or mildly impaired kidney function. It's like upgrading from a basic calculator to a scientific one. You get a much more precise answer. The CKD EPI equation is also widely used and recommended by international guidelines, making it easier to compare results across different healthcare settings. It's like using the metric system, everyone's on the same page. The International Consensus Guideline on Anti-Cancer Drug Dosing in Kidney Dysfunction recommend the use of estimated glomerular filtration rate via the eGFR CKD EPI equation to guide the assessment of kidney function, except where directly measured glomerular filtration rate, or mGFR, is clinically necessary. So now let's look at chemo drugs and their kidney quirks. So here's the tricky part, right? Every chemo drug has its own quirk and in how the kidney handles it. We'll categorize them for simplicity. So there's the kidney superstars. Drugs like carboplatin, cisplatin, and methotrexate are almost entirely cleared by kidneys. A reduced eGFR means trouble with a capital T. Moderates. Many chemo drugs are partially eliminated via kidneys, partially by other routes like the liver. Impaired kidneys still matter, but the effect might be less dramatic. And then there's drugs that are kidney independent. So some of those drugs barely touch the kidneys for clearance. This is where eGFR usually isn't our top worry. Of course, this is a very simplified view. Dosage adjustments in renal impairment can get complex fast with many factors to consider. However, our handy eGFR is a vital starting point. Using that, we go to the dose recommendations for anti-cancer drugs in patients with renal or hepatic impairment. That's a guideline that has been developed by Krenz et al. And then updated by Giraud et al. In 2023. The NCCP are currently updating their protocols to update the old London Cancer Alliance references to reflect the recommendations from this updated documents. So now let's look at that medication safety aspect for those cancer drugs. So when it comes to chemotherapy in the face of kidney problems, think of pharmacists as your medication safety guardians. We're the ones who are meticulously checking for potential dangers before medication even reaches the treatment room. However, it's everyone's job to keep a keen eye for these problems. So let's break down exactly why. So let's catch trouble before it even starts. Remember that eGFR number, that kidney speed limit sign? Well, if you see signs of slowdown, it's like a red flag going up that the usual chemo dose could be risky. But it's not just about the number. You also have to look at the bigger picture. The severity. Is the kidney impairment mild, moderate, or severe? This drastically changes our calculations for a safe starting dose. Guidelines define different stages of chronic kidney disease, CKD, based on those eGFR values, which helps guide dose adjustments. Also look at the trend. So are the kidney numbers stable, slowly worsening, or rapidly declining? These trends can help us predict what problems might pop up during treatment. If a patient's eGFR is declining rapidly, it could indicate an acute kidney injury, which requires urgent attention and potential dose adjustments. And are there any additional risk factors? So does the patient have diabetes? Do they have blood pressure? Are they on any other medications that are harsh on the kidneys? These all make us even more cautious about those chemo doses. Certain medications, like some antibiotics and pain relievers, can further stress the kidneys and can interact with chemotherapy drugs. So let's look at the art of the dose adjustment. So, we spot signs that a patient's kidneys aren't at 100%. So our work isn't done here. Next comes the delicate dance of finding that sweet spot of a dose. So we first need to play detective, right? We need to know exactly how the chemo drug is processed by the body. Is it mainly kidneys, mainly liver, or a mix of the two? This tells us where to focus our adjustments. For example, drugs like carboplatin and methotrexate are primarily cleared by the kidneys, so those adjustments are crucial for these drugs in renal impairment. Drug-specific guidelines. So, as I said earlier on, we don't have to start from scratch. Research studies and expert recommendations like those found in the aforementioned Giro et al. Guidelines give us initial guidance on what those dose reductions might be needed based on the level of kidney impairment. But we also need to tailor it. Every patient is different. We carefully consider age, weight, the type of cancer we're treating, and many other factors when making those final adjustments. For instance, older patients may have naturally lower kidney function, requiring that initial dose adjustment. So why can't we just wing it with the doses? Why not just start at a lower dose and see what happens? So here's the thing about chemo drugs. They have a narrow therapeutic window. For many of the medications, the difference between an effective dose and a dangerously toxic dose is tiny. Too little drug means the cancer won't be effectively treated, but too much can cause life-threatening side effects. It's like walking a tightrope. We need to find the perfect balance. And delayed reactions as well. So sometimes those toxicities from chemo drugs don't show up immediately. They can build up slowly over time, especially if the body can't clear the drug the way it should. It's like a slow leak in a pipe. It might not seem like a big deal at first, but it can cause major damage if left unchecked. So now let's shift gears and talk about carboplatin. That's a chemotherapy drug commonly used to treat various cancers. Carboplatin is primarily eliminated by the kidneys, making it a kidney superstar that we said earlier on in our drug classification. This means that when a patient has renal impairment, we need to be extra careful when dosing to avoid toxicity. So to guide our carboplatin dosing decisions, we turn to the trusty Calvert equation. This formula helps us calculate the exact dose of carboplatin needed to achieve a specific target area under the curve, or AUC, and you'll see that in your protocols, which is a measure of drug exposure over time. The Calvert equation takes into account the patient's kidney function measured by that eGFR and a fixed factor for non-renal clearance. It's like a recipe that tells us exactly how much of each ingredient we need to create the perfect dish. Now, remember that the CKD EPI equation we talked about earlier, it comes into play here too. We use the CKD EPI equation to estimate the patient's GFR, which we then plug into the Calvert equation to calculate the carboplatin dose. It's important to note the ADDIKD, so the anti-cancer drug dosing in kidney dysfunction guidelines recommend using the body surface area adjusted eGFR and Calvert equation, especially when the eGFR is between 45 and 125 mils per minute. This adjustment helps ensure that we're accounting for the patient's body size and avoiding under or overdosing. So combining the BSA with the eGFR in that Calvert equation. And there are many calculators out there to help you use that calculation. So why does the precision matter? So carboplatin, as I said earlier on, is one of those drugs with a narrow therapeutic window, meaning the difference between an effective dose and a toxic dose is small. Too much carboplatin can lead to severe side effects like low blood cells and kidney damage, while too little might not be effective in treating the cancer. By using the Calvert equation and the CKD EPI estimated GFR, we can calculate a precise dose of carboplatin that's tailored to the individual patient's kidney function. This helps us strike that delicate balance between efficacy and toxicity, ensuring that the drug is doing its job without causing unnecessary harm. Of course, our work doesn't stop at the initial dose calculation. We continue to monitor the patient's kidney function throughout their treatment, making adjustments as needed. However, the anti-cancer drug dosing in kidney dysfunction guidelines, that international consensus document, they recommend that a dose should not be changed unless that eGFR changes by more than 20%. So that's a conversation that we need to have with our oncology and hematology teams to ensure that that's a recommendation that they'd like to go with first as standard for practice. Remember, managing renal impairment in cancer patients is a dynamic process that requires ongoing collaboration and careful attention to detail. By using the right tools and staying vigilant, we can ensure that our patients receive the safest and most effective treatment possible. So, just to wrap up here, kidney problems can throw a major wrench into the cancer treatment plans. These organs play such a critical role in how the body handles chemo drugs, and their health can mean the difference between a successful treatment course or one derailed by side effects and complications. Careful attention to that kidney function, along with expertise in drug dosing, helps ensure the medication can do its job safely and effectively. Navigating complex dose adjustments is a necessary skill for all. Thanks again, everyone, and to everyone who tunes in each week to listen, and for all the comments and feedback. Please complete the feedback form in the show notes. Give me an idea of topics, guests, or suggestions for future episodes of this podcast. I hope to continue going through a few toxicities before getting on some guests. If you have any guest recommendations for me, get in contact. I'd love to get those disease type specialists to come on and give a breakdown of each cancer type. If you have anyone in mind, consultants, ANPs, CNSs, please drop me an email so I can get in touch with them. And as always, I'll end on this important disclaimer. This podcast is for educational purposes only. The field of oncology and haematology is constantly evolving, and new research may lead to changes in cancer care guidelines. As always, consult with your cancer care team for personalized guidance and discuss any information from this podcast with them. Seek information from trusted local resources and national resources for the most up-to-date recommendations. Thanks again to everyone for joining me on this episode of the Irish Haematology Oncology Podcast.